Hello, welcome back to EASD TV. Now, one of the things that we've heard about in this studio often are the outcomes of the many trials that are being presented at the Congress. And one particularly important trial was the SOUL trial involving cardiovascular outcomes. And we talked to a cardiologist already. Now let's talk to a diabetologist about that particular study. I'm delighted to have with me Rodica Busui of OHSU in Oregon. And tell me, first of all, just to remind people, what was the SOUL trial?
Well, thank you so much for your interest in highlighting this important trial. SOUL trial actually is the first trial demonstrating cardiovascular risk reduction benefits with an oral formulation of the GLP-1 receptor agonist semaglutide. And this is important because there was skepticism regarding whether an oral formulation, first of all, will be feasible from compliance reason as well as absorbability. The trial primary outcome, which is the classical MACE, demonstrated exactly the same risk reduction in the primary outcome, 14%, as it has been prior demonstrated with these subcutaneous formulations. And that's important because for clinicians, it enriches the phenotypes of patients in which these agents could be prescribed.
So it's a really key point, this, isn't it? Because with the oral formulations, we're hoping that they're going to make treatment much, much more accessible. And possibly you're thinking, because it's not injections, because you can store at ambient temperatures, and we hope they're going to be a much lower price, that you might see prescribing at perhaps an earlier stage of diabetes rather than a later stage when perhaps damage has already occurred. So actually this is potentially hugely significant, isn't it?
It is. However, I think that we need to be careful, as the results of the trial should be seen in the context of the patient population that has been enrolled. And from an endocrinologist perspective, it is important to highlight that this trial was done in people with type 2 diabetes, people who had a higher cardiovascular risk. But as you say, it is an important information that can be applied now, especially since we are poised to deliver personalized care, because it's enriching our understanding of the patients that could benefit. And as you said very nicely, having an agent that it's an oral agent that doesn't require special storage or special additional equipment, even if a once weekly injection is in general accepted, it offers a very important new data. It also offers important data for more elderly patients, giving them the opportunity to take a treatment by themselves in case, an injection may be more cumbersome.
So what does this mean for, I'm going to call them an average diabetologist, although I know you're not average out there. But what does it mean for the diabetologist in a hospital? What should they take from this trial?
Well, first of all, I think that at EASD, we have also highlighted additional information that hasn't been published before, and that is based on the people with particularly heart failure phenotypes. And this is important because it has been demonstrated in the last couple of years, heart failure now it's emerging as one of the most prevalent cardiovascular complications in people with diabetes, and particularly the heart failure with preserved ejection fraction. It's extremely prevalent and grossly underdiagnosed in practice. So having an opportunity to understand, among those people who may have heart failure, that there is potential benefit for this agent, it's very important. In addition, the trial is the only trial that had a very large proportions of people who have been concomitantly treated with other guidelines-directed medical therapy, particularly sodium glucose transporters inhibitors. And as you know, and many of our audience know, the guidelines, including the American Diabetes Association Standards of Care guidelines, do recommend as first-line therapy in the type of people that have been part of SOUL trial, either an SGLT2 inhibitor or a GLP-1 receptor agonist. There were some concerns that perhaps having both may be harmful. Another important finding from the SOUL trial is that with up to 45% of this cohort being also taking an SGLT2 inhibitor, we did not see at all any signal for harm. And that's extremely relevant for clinicians, because since we do not have a trial demonstrating a combination, seeing that in such a large proportion, this combination was in fact not only safe, but did not affect the the outcomes. In fact, the outcome was irrespective of the concomitant use of SGLT2 inhibitor, provides additional reassurance, particularly for endocrinologists and even primary care physicians.
And it strikes me that what you're seeing happening is you've always had kind of two separate streams. You had a diabetologist over here, you had a cardiologist, all these people with diabetes with all these multimorbidities. And yet what you're seeing now is a small molecule that effectively tackles both heart and and glycemic issues. So, and that's incredibly useful.
It is, and I would like to highlight that we should not forget that indeed this molecule was very effective in lowering the hemoglobin A1C, which is our measure of glucose control, as it was effective in lowering body weight, both important component of the overall diabetes care. I know that some of our cardiology colleagues, not all, are considering perhaps the glucose lowering effect less important. But
they're cardiologists.
Yeah, but we need to understand that diabetes, it's a disease that affects the entire human body. And in fact, the reason that all these various comorbidities occur, including cardiovascular, are because of this hyperglycemia, which is the initiating factor, which its downstream consequences. So for eyes, for kidney, for neuropathy, having actually an agent that has this glucose lowering benefit with basically no risk of hypoglycemia, it's very important as well.
So really exciting results, and thank you for explaining them so clearly for us. And I think there's going to be a lot more that we're going to hear about these oral agents. We'll be back very soon, and thank you very much.
And thank you so much for having me. It was truly a pleasure, and congratulations to EASD for such a great meeting.